Welcome to Roadmap to Residency. Today we are diving into diarrhea, one of the most commonly tested topics on the Step 2 clinical knowledge exam. This video is not about memorizing textbook facts. Instead, we are going to work through high-yield question stems and teach you how to think like the test writers. You will learn to spot the buzzwords, apply frameworks, and pick the right answer every time. Before we start, make sure to like this video, subscribe to our channel, and check out our expert tutors and residency advisors at roadmaptoresidency.com. Let us get started. By the end of this video, you will be able to distinguish acute from chronic diarrhea based on timeline and clinical features. You will recognize the classic question stems that board examiners use for infectious diarrhea, inflammatory bowel disease, and irritable bowel syndrome. Most importantly, you will learn the test-taking strategies that help you eliminate wrong answers and find the correct one. For the deep learning, I recommend reviewing First Aid for Step 2 and UWorld questions on gastroenterology. This video is about strategy, not comprehensive teaching. Here is your first framework, and this is absolutely critical. When you see a diarrhea question, your brain should immediately ask two questions. First, is this acute or chronic? Acute means less than 14 days and screams infection. Chronic means greater than 4 weeks and makes you think about malabsorption, inflammatory bowel disease, or functional disorders. Second, what is the mechanism? Is it inflammatory with blood and fever? Is it secretory with large volumes that persist with fasting? Or is it osmotic and stops when the patient fasts? These distinctions will be in your answer choices, so knowing this framework eliminates wrong answers immediately. Now let us talk buzzwords, because board exams are essentially pattern recognition. When you see recent antibiotic use plus hospital setting plus watery diarrhea, think C. diff immediately. When you see recent travel to a developing country with acute watery diarrhea, that is traveler's diarrhea. And when you see chronic abdominal pain that improves with defecation, altered bowel habits, and a completely normal workup, that is irritable bowel syndrome. These patterns repeat over and over on the exam. Memorize them. Read this question stem carefully. Hospitalized elderly patient treated with levofloxacin for pneumonia develops profuse watery diarrhea on day 5 with leukocytosis. Every single detail here is a clue. Fluoroquinolones are notorious for C. diff. Hospital setting is high risk. The elevated white count is a classic finding that boards love to include. This question is practically handing you the diagnosis. Now, what is the next step? Let us walk through this systematically. Step 1. Analyze the clues. Hospital setting, fluoroquinolone use, watery diarrhea, elevated white count. This screams C. diff. Step 2. Know your risk factors. The highest risk antibiotics are clindamycin, fluoroquinolones, cephalosporins, and ampicillin. Other risks include advanced age, hospitalization, and proton pump inhibitors. Step 3. Choose the right test. The answer is stool C. diff testing using nucleic acid amplification or toxin assay. Colonoscopy showing pseudomembranes is diagnostic but is never the first-line test. That is a distractor answer. For treatment pearls, remember oral vancomycin or fidaxomicin are first-line for C. diff. Metronidazole is no longer preferred. New question. Young patient with 3 months of bloody diarrhea, urgency, tenesmus, and 15 to 20 bowel movements daily. Labs show anemia and elevated inflammatory markers. The chronicity and bloody nature immediately tell you this is inflammatory bowel disease, not infection. The question is asking for the diagnostic test. What would you choose? Here is how to think through this. Step 1. Recognize inflammatory bowel disease. Young patient, chronic bloody diarrhea, tenesmus, anemia from chronic blood loss, elevated inflammatory markers. This is textbook presentation. Step 2. Distinguish ulcerative colitis from Crohn's. The bloody diarrhea with tenesmus and mucus is more classic for ulcerative colitis. Crohn's tends to present with abdominal pain, sometimes obstruction, and classically has skip lesions. The definitive diagnostic test for both is colonoscopy with biopsy. That is your answer. Remember, ulcerative colitis shows continuous inflammation starting from the rectum, while Crohn's shows patchy transmural inflammation anywhere in the GI tract. This slide is gold for Step 2. Boards love testing the differences between ulcerative colitis and Crohn's disease. Ulcerative colitis has bloody diarrhea, P-ANCA positivity, increased colon cancer risk, and importantly, surgery is curative because disease is limited to the colon. Crohn's has ASCA positivity, skip lesions, cobblestoning on imaging, and fistulas are pathognomonic. Now here is a favorite test question. Which extraintestinal manifestations correlate with disease activity? Erythema nodosum, oral ulcers, peripheral arthritis, and episcleritis improve when you treat the underlying disease, but pyoderma gangrenosum, primary sclerosing cholangitis, ankylosing spondylitis, and uveitis are independent of disease activity. Know this distinction cold. New scenario. Patient returns from Mexico with acute watery diarrhea 3 days later. No fever, no blood, stable vital signs. This is the classic traveler's diarrhea presentation. The question asks for initial management. This is a treatment question, not a diagnostic question. What do you do? Let us break this down. Step 1. Recognize the pattern. Recent travel to endemic area, acute watery diarrhea without systemic symptoms. This is traveler's diarrhea, most commonly caused by enterotoxigenic E. coli. Step 2. Know when and how to treat. For mild cases like this one, oral rehydration and loperamide for symptom control is appropriate. If moderate to severe, add a fluoroquinolone or azithromycin. Critical teaching point: if there is bloody diarrhea or fever, do not give loperamide because you could precipitate toxic megacolon or hemolytic uremic syndrome with certain pathogens. Instead, get stool studies and start empiric antibiotics. For this patient, the answer is oral rehydration plus loperamide. Next case. Young woman with 2 years of intermittent abdominal pain relieved by bowel movements, alternating diarrhea and constipation, no weight loss, no blood, no nocturnal symptoms, and completely normal labs. This presentation is basically the Rome criteria for irritable bowel syndrome written into a vignette. The question asks for the most likely diagnosis. Here is your approach. Step 1. Apply Rome 4 criteria. Recurrent abdominal pain at least 1 day per week for 3 months, associated with defecation, change in stool frequency, or change in stool form. This patient meets all criteria. Step 2. Look for alarm features. These include age over 50, rectal bleeding, weight loss, nocturnal symptoms, family history of colon cancer or inflammatory bowel disease, and anemia. This patient has none of these red flags. Step 3. Make the diagnosis clinically. Irritable bowel syndrome is a diagnosis of exclusion but does not require colonoscopy in patients under 50 without alarm features. That is a common wrong answer, ordering unnecessary workup. Treatment is symptom-based with fiber, antispasmodics, and dietary modifications like the low FODMAP diet. The answer here is simply irritable bowel syndrome. Last case. Middle-aged man with 6 months of watery diarrhea plus episodic flushing, wheezing, and palpitations. Hepatomegaly on exam. This triad of diarrhea, flushing, and bronchospasm with liver involvement is pathognomonic for carcinoid syndrome. The question asks for the initial diagnostic test. Here is the key teaching. Step 1. Recognize the classic triad of carcinoid syndrome: diarrhea, flushing, and wheezing. Step 2. Understand the pathophysiology. Carcinoid tumors are neuroendocrine tumors that secrete serotonin. Normally, the liver metabolizes serotonin, so you only get systemic symptoms when the tumor has metastasized to the liver or the primary tumor drains directly into systemic circulation. The hepatomegaly in this case tells you there are liver metastases. The screening test is 24-hour urine for 5-hydroxyindoleacetic acid, which is the serotonin metabolite. That is your answer. For localization, you would then get imaging like CT or octreotide scan. And that wraps up our diarrhea question walkthrough. Remember to like and subscribe, and visit roadmap2residency.com for personalized tutoring and residency advising. Good luck on your boards.